So that predisposes you to, in his case, an Achilles rupture. I'm Doc Beisel, orthopedic surgeon with Move Smarter Health. We are sponsored by an educational grant from Kinesi Movement. I love sports. I love talking about injuries. I take care of shoulder and knee injuries, and I operate and treat on them. And please consider this an educational, informative video only. Here we go. So yes, I do have a soft spot for the Colts. I have friends and family in Indiana, so yeah. Was I a Colts fan? I think I like watching them play. I would say that I also did spend some time at Methodist with a couple of the surgeons that took care of the Indianapolis Colts when I trained. So yeah, I got a soft spot for them. So it kind of hurt hearing about a Colts injury. What happened? Well, so this is a good, little discussion about when you get an injury that predisposes you to another injury, or if you get one injury and then you get another injury and then you wonder, are they connected, right? Or could one have led to another? Was it in one is in the one limb, one is in the opposite limb? We get that question all the time from patients, from companies, whether it's a worker comp, work-related injury, whether it's a patient medical legal injury, whether it was a vehicle accident. All of these things relate to, and then for a patient perspective, it's kind of like, well, I did hurt this leg, and then I started overusing it, and so there's a lot of questions that come up. So what happened? So he had a fibula fracture. We believe it's a hairline fracture. Again, a lot of the details are limited because I'm not the treating surgeon. This is private health record information of an athlete, but all we can go by is what's publicly available. So this is education material provided within the context of athlete injuries. So fibula fracture in one limb, then he gets an Achilles tear in the other limb, and now he's out. Right? He was playing with the fibula, so maybe an undisplaced hairline crack of the fibula, maybe proximal upper neck of the fibula. We don't know all the details, right? And then he gets an injury to the opposite limb and gets an Achilles tear. Does anyone remember an Achilles injury that led to an ACL tear in another famous athlete? Played for the Golden State Warriors. Yeah, Klay Thompson, right? So in this particular case, you have one injury in one leg, Achilles in the other. What happened? Okay, so if you have an injury in one limb, what are you going to do? You're going to protect it, right? So what happens when you protect it? You don't move it as much. So when you walk, your overall mobility, and I'm using this, but say you had a fibula here, your swing gait may not be as much. You may not put as much weight on it. Now, we already know that all of us in general, unless you're highly specialized and trained, which he could be, we typically are dominant in one leg versus the other leg. Now, I mean, that is evidence-based. We know that. You look at it as a tennis player. Look at the forearm musculature. Like, has anyone looked at some of the arms and some of the photos of these athletes? Like, if you look at, Tour de France riders, they have massive legs, tiny little arms, right? They're like dinosaurs, right? Tiny little arms and massive legs, right? Then you look at tennis players, massive arms that are hold the racket. And then their other arm, not so strong, And so same with soccer players, same with all athletes. There's always a leg dominance as well. The one you trust, the one you push off of, the one you kick with, tends to be the stronger limb. So say just for example, I don't know which is more dominant for him. Say, for example, his non-dominant leg was injured. Will it make a difference to his dominant leg? Yeah, maybe. Now, what if it's dominant leg that had the fibula fracture? Well, then he can't use his dominant leg. So now he's having to use his non-dominant leg. Or he's using the dominant leg more because the non-dominant leg is injured. So either way, there is an impact. Whatever period of time it is, you're going to protect it. You might have some pain. You may have taken painkillers. You may have had regenerative technology. But overall, your mobility, constraints of motion, and function are all limited by that injury because you don't want to hurt it again. So you protect. So you might move a little differently. Like, did you like that move? Like little, like, you know? Like,
some music.
Yeah, okay. There we go. So either way, whatever you do, your movements are affected, your motion is affected. So if your motion is affected, then you're tending to put more forces and more strain on the good leg. What happens? If you stress one leg more, that means instead of distributing the weight equally, you then have maybe more pounds per square inch or newtons of force, or whatever it is. Work is force times distance, right? So the amount of work required for the same tendon, for the same bone, for the same tissues, for the same, ankle is going to be higher. That means it affects your nerve, vessel, lymphatics, drainage, tissue, muscle, collagen. Everything is affected. Now, if you don't give time for that to build up, then you're going to injure it. And that means that no matter what, you're going to be pushing off of that more. You're going to be like leaning on that leg more. So that predisposes you to, in his case, an Achilles rupture. Not good sound effects. Please add one in. Thank you. Now, and why does that happen? Well, for one, okay, knee, foot, right? There's muscles that go from here all the way down to the foot. There's muscles that go all the way down to the foot. So if you have an injury up here, it affects your overall mobility down here. Okay? Now, okay, it was the opposite limb that got the Achilles, but that means he's not planting as well or pushing off as much, maybe with the bad leg that led to an injury in the opposite leg. Now, let's say, for example, one side was the non-dominant and he was already straining the Achilles. Say he already had a little bit of an Achilles strain. So now he's making it worse because now he's having to put more stress and strain on the opposite limb because of the fibula fracture from the other side. And now we could also argue that, oh yeah, his leg dominance was equal. We know for a fact because we measured on a torque meter that he was putting the full forces on both limbs. Really? Do you really know that? You know that because you tested in a lab where he knew he was being tested, or on a foot plate. So you've got an entire gym floor and you got foot plates and you're testing him. But what is he doing in game, on field? You do not know that. Nobody does. Why? Because we don't have that wireless wearable technology for on-field measurement for all aspects of motion kinematics yet. I mean, that's what we're doing with kinesis. So we know what he's doing in the lab, on a bicycle, on a treadmill, on a foot plate measurement system. And so you could argue that, oh yeah, we made sure that he was equally footed. He had 50% forces on both sides when we tested him. Okay, fine, you're testing him in a lab. So, but you don't really know what he was doing in game or in play. And anyone can call me out on that because there's no data. There's some data on footwear. So there are some wireless kinematics where they have the foot plate inside the shoe. But how good is the data? How valuable is that information? Are you measuring the entire leg and the limb and the knee and the foot plate? Do you know all the biometrics synchronized with all the physiology and all the quantified kinematics of the entire limb, including the foot and mobility and motion with all the toes? I don't think so. So you have to connect everything, right? It takes time. You got to build it. It takes time. So without knowing all that information, you have to sort of suppose what could happen. And just from my experience, when I see patients, when I see athletes, I always find that there is this, disconnect sometimes between an injured and an uninjured limb. And I can tell you, more than 80% of patients will tell me without asking that, this has been giving me problems, but now, since the surgery, this is starting to feel better. But now the other one hurts still because I've been overusing it. So you're always going to get an overuse on one side when you have surgery on the other. It's just natural because you're using something you don't always use. If you were to pick up 2 gallons of milk, you would pick them up one hand each, right? Or maybe you have a bag, but you're going to put it in your dominant arm, not your other arm. And you're going to carry things and put them on a shelf using both hands, both arms. And now you're trying to do that, even though you shouldn't, putting 50 pounds up using one arm. So those are all examples of where an injury on one side can affect the risk of injury on the opposite limb.
Achilles is a year recovery, physically.
It depends. I mean, if you have a clean rupture, you get it repaired, you get it reconstructed, could you be back in 6 to 9 months? Sure. It depends on the sport, depends on the injury. But then there's proprioception, rehab, all sorts of recovery related to it. And you also not only have to get your strength back, but the stiffness of the tissue, that pliability. We use measurements for looking at stiffness quotients for what the stiffness of the collagen in the tissue is. Now, you can't measure that in real time because you're not going to poke someone with a needle and put little transductors and look at the force, transmission across the stretchability of fibers. You can do it in a cadaver, you can do it in a lab. You could even do it in some patients with certain, IRB, but again, it's in a lab clinic testing environment, and you're not going to do it in everyone, especially not a high-performing athlete who just wants to get back on the field. You're going to put little springs and electrodes sticking out from them, whether wireless or not, to measure their collagen function. But you do get stiffness. So that stiffness has to stretch out and become more elastic. So there's this balance between healing, stiffness, elasticity, strength, and the last one, stress. The amount of force it would take to rupture it. So there's a lot of factors involved. And I'm sure, I can guarantee you there's someone who knows physics, even more than I do, in biomechanics. I'm not going into all the biomechanics, who's going to comment down below, but you forgot about... Sure, there's so many different factors. I just mentioned 5, okay? It's all good. It's all good. The most important is understanding that tissue compliance needs to recover. That tissue compliance varies for each individual. So sometime 6 months to a year, probably a year. There's a lot of forces, a lot of body weight going through that. But ideally, you're going to be working them back into their sport after 6 months. And then when do they get back into play? Next year.
Is him walking off the field on it, is that a good sign or does it mean anything?
Yeah, it probably doesn't mean anything because you do have the tibialis posterior, which does allow a little bit of motion. And if you walk, you can walk on a torn Achilles. I mean, I have seen plenty of people walking. They just walk with a stiff leg. They don't push off on it. They use a cane, they might use a crush. But a lot of times, if you have good balance, you may be able to put some pressure, but you can't push off on it. So, and you can't push off, but you do have the tibialis posterior. There are the peroneals. There are other things you can do, but there's some classic tests for the Achilles. You flip them over and you squeeze the calf, and this won't move. Because the calf is the gastrocsoleus that becomes the Achilles tendon, and that doesn't move because on the calcaneus, this is the most powerful pulley-like functional device in the leg, right? The other pulley is the patella. Yeah, you got it. Rah. So here's the good news with Indiana Jones, right? Good news is they got someone to cover for him, but he's retired. Oh wait, no, they just brought him out of retirement. But he's 44. Oh, but he's not the oldest quarterback. That was Tom Brady at 45. My response to that is it all depends on his conditioning. There's a lot of really good athletes out there. And sure, some of them can play well into their 40s. I don't know how this 44-year-old quarterback will do. But let's hope Daniel Jones has a good recovery for next year.